Oh, we're live. Hello, hello. I think I was supposed to put up our graphic first, like this. So we had a second to look like we were mysterious and then pop in. So we'll do that and then we'll say bye. And now we're here. Hey, everyone. Welcome. Today is the first day that I'm doing the live stream on my own. And I'm figuring all this stuff out. It's funny because you always see other people do it and it's so simple looking and it's not as simple as it looks. So shout out to the IOCDF staff and all the hard work you do making this look a lot easier than I just made it. So welcome everyone. Today is a beautiful Wednesday. It is an Ask the Experts live stream. We're so excited to have everybody here, everybody hanging out with us. Can't wait to jump in today. Today's live stream is I have two guests that are just really close friends of mine. I asked them to come on today. I was like, hey, it's going to be my first live stream I'm running. I want support. So this is cool. We got two good friends. So I'm going to introduce them in a second. But before we jump into that, I just want to let people know we have a great show today. We're going to answer your questions. We're going to really talk about OCD. We're going to talk about medication. We're going to talk about treatment. We're going to talk about everything you need to do to get the right resources to make sure you're in the best place possible with your mental health and your OCD treatment. But we always want to remind people we can't be a crisis line. So unfortunately, if you're going through a really difficult time, our heart goes out to you. But please, please, please make sure instead to call 911, dial 988, go to your local emergency room. Please get that support that you need. And as always, the IOCDF has a great find help option on their website where you can find licensed providers, people that are really equipped to help your specific needs. What we can do is obviously offer resources and support. It's all we can kind of do, but we can't step in for a crisis line. And then lastly, this is being live streamed to people all across Facebook, LinkedIn, Twitch, X, YouTube, iocdf.org/live. So wherever you're joining us, once again, this is your live stream. Make sure you say hi in the chat. Let us know where you're from, where are you located, and then who are you here to support? Are you here to support yourself? Are you here to support a loved one with OCD? Are you a treatment provider, a student? Let us know where you're watching from and make sure to like and subscribe whatever platform you are watching on. All right, so I have two great guests today. I'm going to start with Mr. Dr. Patrick McGrath, who is a good friend of the show and a good friend of mine, somebody I've known for a hot minute, and we always have a good time doing these live streams together. So Patrick obviously is the CCO of NoCD. So NoCD is a treatment provider that takes a lot of insurance. They really are giving people access to care that may have not been able to get it before. They're treating OCD and related disorders, as well as have really great trainings for clinicians to get low cost or free CE. So please make sure to check them out. But Dr. McGrath himself has been treating OCD for a long time. He's been on the front lines, really making sure. I never say the years because I'm like
26 years. 26.
I was like,
years.
We're gonna keep it mysterious.
No mystery here. Long time. Almost half my life has been treating OCD. Actually.
Yeah. Crazy. So he's been really just kind of leading and spearheading the treatment for OCD and just making sure that people are getting frontline care at OCD. But even before that, making sure people are getting proper treatment. So anything I missed, that was kind of more the friend intro. So is there anything important that I missed?
Yeah, that's all great, Chris. Thank you for that intro. And the best part is I think supporting evidence-based treatments, and we're working on publications in those areas too, just to make sure to show that the work we do is valid. So I'm always happy to chat with people if they have questions about our work at NoCD, and thanks for having me on.
Yeah. And then we have Dr. Adam Frank, who is a psychiatrist and also a PhD. I always forget that there's people that like school that much. And Adam is one of those who just was like, you know what? It's not enough to get a PhD. I need to get an MD too. So we are so lucky to have Dr. Adam Frank, who is a psychiatrist and also does TMS through USC, can answer questions on both. Also is a fellow board member of mine at OCD Southern California, and is somebody that's presented at the BTTIs and really, really understands not only medication, but TMS and DBS for OCD treatment. So those are some options if people aren't doing well in medication, he can go ahead and support. So Adam, is there anything I missed for yours?
I think that pretty much covers it, Chris. Thanks for the intro.
Adam,
Yes.
with a MD, PhD, are you Dr. Adam, or is
Ooh, sometimes I just like to put the squared after.
That's excellent. I like that. Yes, that's very good.
I know there was when I was in grad school, there was a woman that had 2 PhDs. She came and spoke. She was a graduate of my program, but she went on to get 2 PhDs. And she's like, yeah, technically, like I'm supposed to be called a doctor. And I'm like, wow. I'm like, I just like to be called Chris and not F you,
Yeah.
get out of my way on the freeway.
Yes.
But this person is 2 doctors. So I'm like, this is incredible.
Yeah, it's a lot of schooling.
Yes. Well, one really quick thing before we jump into all of your questions, we're going to start, just so everybody knows the agenda today. The 3 of us are going to kind of just chat about OCD treatment, kind of just general conversation. Probably you'll get a lot from these 2 really, really brilliant men. Make sure to kind of pay attention. But while we're doing the live stream, please get your questions in the chat. This is your live stream. This is your opportunity to ask these 2 questions, anything that you have curiosity about. Information, resources, etc. Make sure to ask those questions, and then that way we can make sure to involve you. So can't answer questions that you don't ask. I also have a lot of pre-submitted questions as well I can jump to, but make sure to put that. But before we jump in, I'm going to see both of you this weekend. So excited.
I heard there's a conference this weekend. Yeah, something like that. Yeah. Mm-hmm.
Yes, if you are just joining us and haven't been watching the live streams the last couple of weeks, this Saturday and Sunday. So the International OCD Foundation has affiliates all across the globe. And they are, global partners, but affiliates here in the United States. And OCD Southern California is one of the affiliates. And we're hosting a 2-day conference this Saturday and Sunday. It's from 9 a.m. to 6:30 p.m. on Saturday, 9 a.m. to 3 p.m. on Sunday. Those are Pacific Standard Time. But we're going to have Adam Frank, who is one of the board members. He is going to be doing a lot of behind the scenes and making sure the conference runs smooth. And then Patrick McGrath, we have 2 events together. We are going to do a live call-in show like this for after hours on Saturday. And we're going to be talking to clinicians also on Saturday about how to use your own lived experience to really support your clients and find that balance. So gentlemen, are we happy? Are we excited? How are we feeling about it?
Absolutely. Very excited. Looking forward.
Super excited.
Yes. So I'm putting this is where you can go to register. There's low cost options. Also, we are offering scholarships. So if you need a scholarship, make sure, I'm so bad at doing 2 things at once, but we're learning, kids. We're learning. If you need a scholarship for free entry, just make sure to email us. We will go ahead and offer you free entry. We've gotten some generous support. So you can offer scholarships, and just go to this website. That's where you'll find out more. And after that, the following week, there is the OCD Faith and OCD Conference. So the International OCD Foundation has hosted an annual Faith and OCD Conference, and they're hosting one next week. So people are going to be busy, like Katie O'Dunn and stuff. So shout out to that. And then finally, if you have any curiosity about what the IOCDF affiliates, et cetera, are offering throughout the year, make sure to head over to their calendar to check that out. All right, so we are going to jump in with just general conversation. So I'll start with you, Patrick, and then I'm going to jump to you, Adam. Patrick, what are you guys seeing at NoCD? I know you posted some research that you've done recently, just about, really, really good numbers that people are getting better. I saw a post on Instagram about somebody just talking about, ERP. He didn't get it yet. He was kind of thinking about it, but should he do ERP? He was just kind of like posted a video. He's like, I have OCD. I finally found out what ERP was. And most people in the comments, thank goodness, were like, yes, I've been through it. It's life-changing. Therapists were like, I've done it. It's amazing. But there were people that had a lot of questions about OCD treatment. They're like, you can never get better. You're going to be stuck in your head forever. If you have more obsessional OCD, where it's, shows up more as intrusive thoughts and mental compulsions, there's nothing you can do. People were like, I just looked it up and it sounds like you're going to be, it's like a haunted house all the time. So just for people watching, what do you see with people with treatment getting better? What does that look like? What myths can we dispel?
Well, it isn't the doom and gloom that some people say. Let's start there. And Chris, you're a living example of that. So I always appreciate your work in this area when you talk about what you've gone through. But a lot of clinicians, unfortunately, who aren't very well trained in OCD, only see physical compulsions, and they don't pay a lot of attention to the fact that there are mental compulsions. And many people with OCD think they don't have OCD if they only have mental compulsions, because you don't see mental compulsions on television and and movies, and no one talks about those. We don't. There's not even, and not that I make jokes about OCD, but there's not even little jokes about mental things really that go on. It's usually about the physical things, right? So everyone has this notion that it's the physical side. And so I think it takes a few things to happen. Number one, a therapist has to ask the question, is there a mental compulsion going on? And number two, the person with it has to really be willing to talk about the things that are going on in their head, because maybe there's some quite taboo things that are going on in people's head, right? Maybe they'd be more willing to talk about the stuff that people can see and are physical, because they haven't been judged as badly on that as they think they would be for the stuff that's going on internally. And it takes that good rapport building with a therapist to make sure that you create an environment that's comfortable enough for someone to be able to tell you anything that's going on mentally or physically. And it's on the therapist to really describe to somebody who has OCD what mental compulsions are, so that people with OCD can recognize, oh, wow, I had no idea that was actually part of OCD, or that was a mental compulsion. I thought I was just the only person that did that, because no one else has ever talked about it. Well, yes, of course, because it's quite secretive for many people, because they don't want to talk about it, because they're afraid, if I reveal some of the things going on in my head, what will people think about me? So build that rapport, make sure the clinician is asking these questions, and then create basically a room for honesty, right? And testing, where people would be willing to take the next step and say, well, I also think about this. Okay. I think about, wait, you're telling me I could say absolutely anything in here and your head's not going to explode? Yeah, pretty much that's what's going to happen. So building that trust and that rapport, I think is the first step.
Yeah. And before I jump to you, Dr. Frank, why do you think that's one of the things I wanted you to dispel, is because I just see that a lot, just people posting, like, they'll say, I have pure OCD. That means I can't get better. I have these thoughts all running in my head all day. I can't make thoughts stop. How do you explain to people that, hey, like, there isn't one type of subtype that gets better. You don't have to have this type of OCD, and that means you're going to get freedom. This type of OCD, people just kind of suffer. Like, how do you make sure to navigate, and how do we navigate that publicly? Because I also look at NOCD as one of the organizations that's really spearheading getting the word out about OCD. How do we let people know that there is help? People are getting better. Obviously, I could talk about it too, but but you guys are doing great work. How do we let people know there isn't a better subtype, an easier one? Mental is better than this, or treatment works better for that?
These types of things are so important to have these conversations. I do a webinar every Wednesday night. Chris, you've been on that with me. Adam, I'll have to have you come on. That would be a joy to have you there. And the podcast that we do, the education, the publications, all of the things to show out there that there is no area that we are not willing to talk about, right? Nothing is off the table when we're treating OCD. OCD would like everything to be off the table, and for you to never talk about anything with anyone, because OCD wants to have this exclusive little club with just you and your brain, so that you will just keep doing compulsions and feeding OCD. And we want you to take that first step. I love the phrase, you can't be brave without first being afraid. And a lot of people are afraid to take that first step, to talk about what's going on in their head and what they're doing. But once they do that, and they take that brave step to do it, and they meet somebody who's like, oh, we could treat that, that's not a problem. The relief that I see on people's faces is amazing, knowing that they don't have to live the rest of their life doing OCD's bidding.
Yeah. Well said. I'm going to put this up before I jump to you, Dr. Frank. But, therapists always say they have to report child abuse, et cetera. It makes it hard to really focus on OCD fears. at risk of being implied a weirdo, like fear of, kids like harming
Yeah.
a child. Can you talk to that before I toss in Adam? I mean, I think that's
Yeah.
what I hear from a lot of people. And I think that's one of the reasons why people don't get help. They're like, what if I open up to a therapist about my intrusive thoughts, the taboo nature? Will I be reported? Are people going to judge me, etc.?
I have worked with people who are afraid of what if they would harm their own children, other children, elderly people, pets, you name it. That what if I walk past a school and I think about taking a shot at the school or something like that? I don't even have a weapon on me, but what if I somehow did and I don't even know? All these things. I've never reported anybody for anything like that. I don't report what ifs. I would only make a report on I'm going to. Not what if I were going to, but I am going to, or I just actually did this, not what if I did this and I don't know that I did it, right? So I'm always looking at those clarifying questions, and those what ifs are there. I would contend one of the definitions you could say about OCD is it's a yeah, but what if disorder, right? And because no matter what logical answer you give it, it's always going to say yeah, but what if. So unless there's an absolute ironclad definite answer that I'm getting from someone that something has happened or I see the evidence of it, it's not reportable because it's a what if I were to have done something.
Yeah. And I like this too. Like, OCD, Ash is a provider. And that's what I like to think about too, is like what you were just saying. There's a big difference. Us clinicians know the difference. If this is one of the reasons that you're not really seeking out treatment or you're embarrassed to tell people about OCD, this is one things to remember is like, there's a big difference between someone saying like, I am going to do something and we have to report it versus someone's like, I don't want to do this thing more than I don't want to do anything in the world, but I have thoughts about it. And I need help. I need support. And that's a huge difference. And we know that's why I always say working with an OCD treatment specialist is so important because we absolutely know what OCD looks like. And we know that you're here to see us because it causes you so much distress.
I would echo that, Chris, like working with somebody who has experience treating OCD and sort of knows as people are describing these things, there often or almost always is that like, what if, and I would never want to do this. But if you're not sort of primed to ask that as the therapist, it might be harder to kind of determine that these are these intrusive, unwanted thoughts that are ego dystonic and not something that people are, actually thinking about. Sometimes sort of those intrusive thoughts of suicidality also come up and can like raise red flags if a clinician isn't primed to sort of ask carefully about what does that mean for that person.
Yeah. And like you were just saying, OCD is ego dystonic, meaning this is not something that we want. It's against our values. It's against who we want. And that's what really makes OCD. It's very different than people who come in and I'm not that kind of therapist, so I don't know if this really happens, but we don't have people coming to us, the three of us, and saying, look, like this is my plan tonight at 7:00. Just want to warn you, it's like people are like, please no, this is against who I want, etc. Dr. Frank, how does medication come into play? So people are experiencing, maybe they're having a lot of intrusive thoughts about a past event. They're finding themselves kind of spinning around it, fixated on that past event. Did I do it? Could I have done it? Am I this bad person? Or maybe, they're really struggling with the fears that they're going to harm their child, or they're washing their hands a lot because, they're afraid to give someone an illness. What is the role of medication? What are we hoping that it does? And when does somebody know that, hey, maybe this is time that we should be using some medication?
Yeah, I think I'll start broadly and just say I'm always optimistic about treating OCD because we have so many different modalities that are evidence-based and can help a lot of people. CBT with ERP being one of those, medication being another, and those two can happen independently, and they sometimes do for certain people, and they can happen together. I think, for individuals thinking about medication, we have lots of options. Generally, the sort of SSRI medications are our first line for treating OCD, and we have lots of studies supporting those different medications and those being generally equally effective sort of at a population level. And usually when medications are helpful for people, it's not an overnight thing. People don't take a medication and the next day feel like OCD has vanished. It's a gradual process, typically over weeks to months. And often people describe it sort of like the intrusive thoughts don't go away, but maybe they're a little less frequent. They're less intense. That sort of like reactivity that comes with those is less bothersome. The sort of drive to do compulsions or rituals feels a little like the dial's just kind of turned back. And often that's a perfect time for people to then, if they've been having a hard time engaging in ERP because any exposure is just feeling like too intense. If we can dial that knob back a little bit, that's a great time to have people connect with a therapist and also engage in ERP as well.
And for a lot of people, one of the things that I hear is that either they've been on a low dose of medication because a provider doesn't know OCD meds, or they've given medications a try, but they've stayed on the medication maybe for a few weeks and then jump ship. What is just like a typical, I mean, we have obviously, Patrick and I know, like, we tell people, hey, like if you've been doing 12 to 16 sessions, you should see change. You should see like a good understanding of OCD. You're starting to see a change. You're noticing you're getting time back. You have a good understanding of what's going on. What does that look like? But for medication, what should people be doing to make sure that, they're giving it enough of a try before they jump ship?
Yeah, I would say, everybody is unique. And so at least in my own practice, I'm working sort of collaboratively with individuals to figure out what makes sense for them. I would say treatment guidelines suggest that we get to kind of a standard expected dose and stay at that dose for somewhere between 6 to 8 to 12 weeks for OCD to really see if we can get benefit. Some studies suggest also that higher doses than we might generally use for anxiety, depression can be helpful in some individuals with OCD. And so that might look like, 250 or 300 or 400 milligrams of sertraline, or 60 or 80 or 100 milligrams of Prozac. I would say not everybody needs to get to those higher doses, but some people definitely benefit from getting to those higher doses. As with any medication, there's the potential for side effects. And so we're always sort of weighing, are we getting benefit? Are there side effects? Are those worth it if there is benefit? And that's kind of an ongoing conversation over time.
Yeah. What are some things, Dr. McGrath, give hope? I saw you guys on social media post yesterday, I think it was, about a success story from NoCD, and she was just talking about like her treatment and how well it went. What are some of the things you've seen either when, prior to NoCD or in NoCD? Like, what are some of the things that you witness with people with OCD, how their lives have changed?
Well, just in the fact that they're now driving the things that are going, they're making decisions based on what they want, not what OCD wants. They're allowing for joy in their life. They can smile. I mean, I've seen people who thought that from a moral scrupulosity point of view, it was immoral to laugh, because what if somebody was having a bad day and you were laughing over here and they thought you were laughing at them, and then that made their day even worse, and what a terrible person you are. So OCD will grab onto absolutely anything and ruin it. I I talk about OCD being, I was in marching band, and the worst thing you could ever be in marching band was following the Clydesdales or one of the horse troops, because you can imagine what the horses left on the street to everyone. And you're marching looking ahead, but you've got to kind of go like this and veer around. And I think of like OCD as just being 9,000 horses in front of you while you're walking down a road, and you've got to dodge all of these landmines. And if you don't, you're going to step right into it. And we know that nobody wants that, right? And so what if we just allowed you to realize, hey, even if I step in it, it's not actually true or real. It's just a mirage. The other thing I'll say is, imagine if I brought you to a football field, right? And I stood you in the middle and you looked around and it's totally flat. And then I put a VR goggle on you and I turned it on. And now I said, look down, and now there's a cliff in front of you. You logically know that you're on flat ground, but you emotionally feel as if you're about to fall. And that's also what OCD can be like for people, right? I know logically nothing's happening here, but what if this were actually true in this situation? And would it be best for me just to take a step backwards anyway, just in case suddenly a cliff did actually appear in front of me, even though I know it didn't?
Yeah. And I think what it is like what I always like to think about what I felt in my own brain, but obviously what I think people with OCD are experiencing as well is like our brains are broken in the sense that it's like that alarm part of our brain, the part of our brain that's telling us something's wrong or could be wrong, or we could be somebody we don't want to be. It's so overactive, and so we are surrounding us, there's not really anything going on, right? People are in the same mall as us, or people are in the same car as us, or people are at the same job as us, and everybody's relaxed, but we have this like internal struggle, and we are thinking like 15 steps ahead, and it's like that meme with all the numbers in the background, and it's like, but this could happen, and this could happen, and this could happen. And part of what I tell clients is the treatment is acceptance. It's letting go. It's saying, look, those things may or may not occur, but I'm going to be able to address them if they do. I have some faith in myself that I'll be able to land on my feet and handle this. And if not, we'll figure it out then too. But, everything I've been doing for the last 10 years hasn't been working. Let me try something else. And that's tough. Those of us with OCD hate change. But I think, we hear so many success stories, and people just need to have some faith that they can get better too.
Yeah.
And same with you, Dr. Frank, like people that either are on medication, or let's say they utilize TMS for OCD, like what are some of the things you see in your practice when it comes to change that we can give a little bit of hope to everybody watching?
Yeah, I mean, I think similar to what you guys were describing, that sense that things can be different, and having that experience of improvement, and then that provides a little bit more optimism for like, oh, this is like different than how I've been experiencing myself in the world, and feeling positively about that. Whether that's with somebody who hasn't tried medication before, and that's helping support their OCD journey, or has tried meds, has tried therapy, is looking for sort of other things that might be helpful, like TMS or DBS for OCD. Interestingly, there have been some studies that have just asked people subjectively what has their experience been when they've benefited from some of these other neuromodulation treatments, and the descriptions are strikingly similar to what people describe when they're noticing improvements with SSRI medications, in terms of like the volume being kind of dialed back on kind of the intensity and the frequency of intrusive thoughts, and drive to do compulsions. So I think that's just interesting that we're targeting something, very different ways of targeting that dysfunctional brain activity, and yet the subjective experience is similar when people are noticing improvement from OCD.
Yeah. I'm going to jump into some questions. We're going to get a lot of questions. I want to throw up a pre-submitted one first. Someone sent this the other day. They said, I'm finally facing my mental compulsions due to ERP. So they finally are in treatment. So I was like, whoop, whoop. I get scared and freeze at the same time. Is that common?
Oh, the freezers. Yes. The idea that if I have this thought or image or urge in my head and I complete an action, then I'm tying that action to that thing, and forever they will be entangled with each other. So it's best to freeze, clear my mind of whatever that is, and then I can continue on with the action, and that will then prevent that entanglement from occurring. Now, let's see. I'm going to try something, and let's just test it. I'm thinking that Chris is going to spontaneously combust if I move my hand. So let's just, nope. Oh, okay. It didn't happen. Maybe I got lucky that time, or maybe there's not really the link there. But with OCD, possibility equals probability, which means if I think it's possible, it's also therefore highly probable. You just got lucky that time, but the next time might be the time. So it'd be best to make sure that you clear that next time so that Chris doesn't spontaneously combust, because now you've used up all of the luck. There's no more left. So Chris is definitely going to catch on fire next time I move my hand, if I have that thought going at the same time.
Well, first of all, I'm so tired from putting on this conference. So if I were to combust, I'd actually welcome it. I'm so tired. I'm like, that's fine, actually. But no, one thing that you say, and what I always tell clients, Patrick, is like, because you'll do that experiment, right? And then they'll naturally say, well, it didn't happen this time, it's going to happen again. I'm like, if you had somebody in your life who called you up and said, hey, can I borrow some money? And you're like, of course. They're like, I'll pay you back this weekend. If every weekend comes up, they're like, hey, I don't have it this weekend. I'll get you next weekend. But can I borrow more? I can't right now. You're going on Instagram. You're seeing them fly to Barbados. They're, have a new Rolex. And they're like, hey, can I borrow some money? At some point, you're going to say, I have been lied to and scammed over and over. Why would I believe this person now? Yet with OCD, we could have it for 40 years. And it's like, but this time it might happen. It's like, we don't do that to people.
Right.
We don't let ourselves get lied to repeatedly. Why do we let OCD lie to us repeatedly?
Yeah, and I think part of that is the triggering that OCD does of that fight, flight, or freeze response. To many people with OCD, it almost feels as if this is an entirely new experience. Logically, I know I've done this 10,000 times, but emotionally right now, it feels like this has never happened before. This one's different than all the other ones. So in case it might be, it would be best to still do that compulsion anyway, just in case.
Yeah. For you, Dr. Frank, could the neuroepinephrine boost from SNRIs help with an ADHD comorbidity?
That's an interesting question. I think theoretically, probably, possibly, some of our non-stimulant medications for ADHD, things like atomoxetine, are pure NRIs, norepinephrine reuptake inhibitors. So possibly, if we're getting a little boost of norepinephrine from an SNRI, that might help with some of that ADHD symptomatology.
Is there anything that people have to think about, like somebody with both ADHD and OCD? Is there anything they have to do differently with medication, or is it really just making sure they have the right medications for both?
I would say in those individuals where those things happen together, which is relatively common, that we should think about treating both. And I certainly have worked with individuals where we've really worked on treating OCD and hadn't fully addressed ADHD, and the benefit that they're getting from OCD treatment is limited. Once we're then addressing ADHD as well, it can make really a world of difference for people. So I think thinking about treating both of those makes sense. Sometimes people worry that stimulant medications can worsen intrusive thoughts and compulsions, and studies have shown that doesn't really bear out when we're looking carefully at people who genuinely have OCD and ADHD, and we're prescribing appropriately for them.
Well said. Patrick, this one's for you. I just started therapy on OCD. How would you recommend dealing with the internet and social media? It's so triggering for me. I feel triggered by everything. So obviously social media, internet, a lot of times too, there's stuff being posted that's not regulated on certain sites, and you click something and you see a video you didn't want to see.
Wait, I thought everything on the internet was true, Chris.
It's true, and it's no longer taken over by AI. Every day it's like a new AI video, and I'm like, I know it's AI, but barely. And in a year, I won't know what is real and what isn't.
Right. I think there's a new one now of people in Africa, and a leopard jumps up and drops the cub off in one of the people's laps and then leaves it with, it's amazing how real these things are looking. And you're right. It's frightening to think about. And I could see why people with OCD will be, obviously we're all confused by it, and someone with OCD would be really confused, because even if in that existential OCD experience, what can I believe? What is true? What is real? How do I know? Right. And so everything could be triggering. And I think we're all together kind of evaluating how we're going to deal in this world where things are going to appear to be real and things are going to appear to be legitimate. And there's a fine line here, because on one hand, what do we say to most people without OCD? Well, do your research. Well, when you say that to someone with OCD, what rabbit holes are we asking them to potentially go down if that's part of the way that they try to figure things out, is to research and research and research and research. So I think that this is an exciting area for us as an OCD therapist to figure out and navigate, and probably requires us to have a couple of meetings about on like the training committee and various things about how do we help assure. Maybe there's some kind of seal of approval or something like that some of us come up with to say that this has been looked at and documented and we believe it to be true. But Chris, we make the joke about there's also people out there saying celery juice will cure OCD, and if you just juice your celery well and get all the bits out and have a good drink, you'll poop it out, and that'll be gone. You don't have to worry about it, right? So probably what I would do working with someone is start off with some limitations on social media at first, just taking a look at building that into our exposure and response prevention hierarchy and homework. How do we get people to first walk away from it? Because there might even be a little bit of a detox people have to do. I mean, how many of us have said, I'm just going to look at one video and 3 hours later, we're still scrolling at something? How do you get people to kind of come off of that experience, live life that isn't just connected to a screen, and then slowly and gradually, reintroduce it, but with limits, so that people aren't overtaken by it and go down these rabbit holes that can be so. And Adam, I'd be interested in you. I don't know if we've done enough research on this, but I think there is an addictive quality to these short little videos, and that people watch and just keep scrolling and scrolling and feel like they can't walk away from.
Yeah, I think the research is still forthcoming, but certainly these algorithms are well tuned to hook us into continuing to watch and scroll and watch. We've been doing some qualitative work, asking people with OCD and clinicians who treat OCD their experiences with technology and how that interacts either in a helpful way or a less helpful way with OCD. And social media certainly is one of these topics that comes up that can cut both ways. Sometimes people learn about OCD and that their experiences have a name, and that is OCD, through social media. And then it can go the other way, where it has this sort of like exacerbating quality for certain types of obsessions and compulsions. So it's an interesting domain.
Yeah, I think if anybody wants to learn more about it, it came out like right during the pandemic, but there's a documentary on Netflix called The Social Dilemma, and they really go into that, and they talk about how they've hired like a lot of people that create slot machines for Vegas, like trying to recreate some of the same stuff, like the noise, the sounds, the bright lights, etc. And that's why more social media sites are going to shorter videos. And I've seen clients, man. I mean, I've seen clients like, I'll come out to grab a client in the waiting room. I had this 13-year-old client, and I could see, because the way that the chair is, I could see him on TikTok, and it was like he'd watch not even, I'm like, the video's 14 seconds, but even that was too long. It was like boom, boom, boom. And I'm like, there's an impulsiveness to it. And, in OCD, although we're compulsive and we overthink things, sometimes there is an impulsivity when we're like fixated on something, we're scrubbing or we're Googling, and it's just, I can't imagine it's great. I can't imagine the studies are like, no, it's awesome, keep doing it. I think it's going to be pretty clear. I like this question for both of you. It says, what's the one you've had in your clinical careers that someone may think is small? Because I think sometimes, people with OCD, we don't always give ourselves credit. But it ended up being like a huge win for the client. So maybe either like you guys knew it was a big win, but maybe small to their families, or something that they didn't really recognize it, and it was huge for them.
Boy, I think something as simple as a handshake could seem so small to most people because it happens every day. But to someone who's had a family member who's looked at them as if they are full of germs and don't want to touch them, who's willing to take that risk is a big piece. Or to drive somewhere, even if it's down the block, right? It just, what anybody might think is just, well, everybody does that. Why is that a big deal? And someone with OCD might even think that once they've done the ERP, if they've never done it before, it's a big deal. It's a huge deal. And it's something to celebrate for sure. The first date that you maybe went on, the first kiss you've ever had, those are big deals when we're teenagers. What about if you're, over 75 years old and you've never done either of those because of OCD, and you've suffered for years and years, decades and decades of that? Those things are huge. And that's why we celebrate every win. And I hope everybody does.
Yeah. And I think it can look very different for different people. What one person might think is like a tiny step can be a huge win, depending on like what OCD has been holding you back from doing.
Yeah, I presented a case at the BTTI in Long Beach. It was the advanced form on pediatrics, and it was awesome. My client actually came with his parents, and we did a presentation together. And it was like we were just talking about it. But I remember The OCD he had was contamination around chlorine and sunscreen, and he was like a swimmer and a surfer, and obviously it was making it difficult. And like one of my goals as a clinician was just like he really wanted to do high school swim, and he was like on the fence about dropping out. He ended up sticking with it and ended up doing varsity. And like for me, that we were talking about on stage, that was just such a huge win, because sports kind of kept him at, not that he was a bad kid or anything, but there's a lot of stuff going on in high schools and kept him out of trouble. It kept him with his friends. And I was like, man, to have given that up, because the OCD would have been terrible. I wanted to throw this comment to both of you, and then I have a question for both of you. But Beth is just talking about, like, you know, all the weird things she was doing. She talked to a friend about it in the 80s. They didn't share it with anyone. I know Patrick and OCD has a lot of support groups. Adam, you know, you do a lot of stuff through OCD SoCal that creates community. Why is like, you know, in the 80s, people didn't have that. You know, this was taboo. People weren't opening. People weren't sharing. So Patrick, I'll start with you, and then Adam, for you, like, why is community, I know you guys run support groups, why is that super important, you know, to really make sure that you have people to talk to this about?
I just like the idea of that you're not alone. I think of our friends at Not Alone Notes. You know, what are they trying to do? Just help people feel that they're not alone. So many people have, one of my former CEOs, I loved he used this phrase all the time, terminal uniqueness, this idea that I'm the only person in the world who's ever had this thought or this image or this urge. And therefore I'm alone and I'm isolated because I can't share it with anybody, because what would anyone else think? Because they've never even thought this. And then to go to a support group and to hear 20 other people say that they have something the same or very similar, you kind of look around and go, wait, I'm not alone. I'm not unique. And just the deep breath that you can finally take in the world, knowing that, oh, wait a minute, that they didn't write these books just for me. If they mentioned something similar, they wrote it because thousands and hundreds of thousands and maybe millions of people have these issues too. So that's what I love about it is I'm not terminally unique.
Yeah, I mean, I would echo that sense of not being sort of alone with this, these thoughts that can feel isolating, and having gone to some of these, you know, some of the events that we have, Chris, here in Southern California, and seeing this sense of community and like feeling that with individuals who travel sort of up and down the coast in Southern California to go to these different events and recognize other people that are also, you know, coming to these events. And it's just, it's really heartwarming to see that community is there, and that people feel supported, and connected to others, and not alone in their OCD.
Yeah, it's awesome to see. You know, one of the things is people with OCD don't only have OCD, right? They have co-occurring disorders. And Shelby says, you know, I've benefited from OCD therapy, and now we're going into trauma of the past. And emotions, and therapy feels worse when OCD therapy is relatable. I think OCD does PTSD work. Mm-hmm. Obviously, Adam, you're working with people with this. I see people with this. One thing I notice sometimes is as people's OCD get better, I know this happened in my own personal journey, some of the other stuff, past trauma, other difficulties, other co-occurring disorders kind of come loudly. So is this something that we see, that as somebody's OCD gets better, if there's maybe some other untreated stuff that can get louder?
Absolutely. And don't ever forget that OCD is a really opportunistic disorder. So if you've had something else happen, OCD will say, well, I can prevent that from happening again. Do these compulsions and those things will never occur. And then OCD will try to ingrain itself into other things. You know, if you look at OCD as this entity idea that I sometimes describe it around, it just wants to live. And so it's going to embed itself anywhere that it possibly can so that it sticks around as much as possible. And it's only fed by compulsions. So if you want it to live, you do compulsions. If you want it to not live so well, you don't feed it anymore. And yeah, absolutely. So OCD will grab onto anything and say, oh, you had that happen? I can prevent that. Yeah, just here's a lovely compulsion to make that never happen again. Yeah. Mm-hmm.
Yeah. Adam, for you, there is a question. I just had it. So many questions. So I'm trying to, here we go. My son has severe OCD. He's been on 40 milligrams of Lexapro for 6 months, plus 0.05 of Klonopin, still struggling with hand washing, etc. How much can his doctor go up with Lexapro?
Yeah, it's a great question. And I would say, there are sort of treatment algorithms that help guide us in thinking about, what medication classes to choose from. If a given medication isn't helpful at a particular dose, what is another, reasonable sort of maximum dose? If that's not helpful, what's another medication that we might think? Are there other sort of augmenting strategies? So like combining different medications together in that SSRI class. And so Lexapro is the brand name for escitalopram. That's one of those sort of frontline medications. And we have a relatively wide dose range for that medication. As we get to these higher doses, we do want to be mindful of, interactions with other potential medications that people are taking, and making sure that there isn't an effect on, for instance, cardiac function, or other side effects. For Lexapro, 40 milligrams is double the standard dose that we're typically using. Usually that's 20 milligrams. I have a few people that we've gotten up to a higher dose, up to 50 or 60 milligrams of Lexapro. And again, monitoring carefully to make sure that as we're going to these higher doses, that we're starting to see some benefit, and that side effects are manageable. And for some people, that a given SSRI medication may not be particularly helpful. It might be reasonable to consider an alternative SSRI medication. Again, at the population level, they all seem to work equally well, but at that individual level, different people have different experiences and different sort of side effect profiles as well.
Well said. Definitely talk to your prescriber. This is something we hear a lot. It says, I really get my mind so filled with fearful thoughts and images that I have to do compulsions to calm my system down. And now I'm stuck. I feel like whenever I do something or not, it's going to happen. So I think what it sounds like is, for so long, somebody was doing compulsions to try to stop something negative from happening. But now they're feeling like, oh, I'm doing compulsions and they're not really, doing the same thing. Why does that happen? If somebody's giving it a compulsion for year after year, how come it gets to a point where pretty soon those compulsions don't even really create the same calm that they did at one point?
Adam, do you want to take that? Go ahead.
I mean, I think one way to think about this is sort of the idea of habituation, that your system sort of gets used to the state that it's in. And I think for some individuals, the compulsions, it sounds like this person is recognizing that they are sort of engaging in those. I think sometimes they almost become sort of second nature, and people don't even realize that they've had the intrusive thought, they've done the compulsion. It's sort of like a single process that we then need to sort of slow down and sort of break apart and really figure out where is the intrusive thought, where is the compulsion, and how can we kind of separate those two so that we can work on them. I think that's something that I hear, where people are like, I don't have compulsions, because it's become sort of so ingrained that they're not even recognizing that that's happening.
Yeah.
I'd also throw in there, I don't believe that practice makes perfect. I believe practice makes routine. And the more compulsions you do and the more routine they become, they just seem to be now a part of your life and something that just is automatically done. Mm-hmm. And the other thing that's in there where they said, I feel like no matter what I do, this is going to happen. I'm always wary when I hear that phrase, it feels like, because I would ask the two of you, what couldn't I justify starting off with the phrase, it feels like? Right. So if I said, Chris and Adam, it feels like you two have really hated me this entire interview and have dissed me totally, and I'm really disappointed. And I think I'll be reporting you to the IOCDF after this. Now, even if I have zero evidence for it, as long as it feels like that, to me, it's truth. To me, it's real. So when I'm working with people with OCD who always say things to me, yeah, but it feels like, I want to challenge that and get them to recognize just because it feels like doesn't mean there's evidence for, or that it's actually got any truth behind it whatsoever. So can we move beyond it feels like, and can we actually test it and see what it is like?
Yeah. And the other thing I always remind people is that feelings are very different from it, you have an option to respond to feelings. So if I'm driving and I'm feeling tired, that doesn't mean I have to just close my eyes and go to sleep on the middle of the freeway, right? I can have a feeling and recognize like I don't want to do the thing that I usually correlate or link with that. And so we have that ability to feel like doing something, but making a choice to do something drastically different. I think that's important. This is a sweet question, so I'll answer it. Callum says, for Chris, what are the words you would say to yourself, in the morning as a survivor of OCD? I was thinking about it. I went to a concert. My best friend came into town from, he lives near Vegas, and we went to a concert in LA. And I had just done like a live stream thing that morning. And so like OCD was fresh on my mind. And sometimes I forget, I'm just like engaged in life and I forget like, oh my God, everything used to be so hard. But I'm at this concert and there's like, people are vaping and smoking some weed and like there's alcohol being spilled. I also didn't like being in like crowds because I used to have this like thought that somebody's going to push me or bump into me and I'm going to attack them. And then my brain's like, what if somebody attacks your friend? You're going to have to defend them. And what if you kill them? And then you have to go to jail and you're, all this kind of mess. And that really wasn't what I was focusing on. If anything, I was focusing on the dang cost of a water bottle. I was so thirsty and I'm like, $10 for water? Like, no, I'm going to go to the sink and just sip it out and enjoy the metal that's in it. But my point is like, I think one of the things, Callum, that I have said to myself every single day is like, OCD I will never allow it to have any influence over any choices I ever make. And I don't want to prevent me from living full experiences. We were talking about in my support group that I run last night. And there was somebody who's like, I feel now that I'm better, I feel anxious all the time because I feel like I have to make up for years lost and I have to do 50 things in a day. And if I'm just relaxing and watching Netflix and I get a matcha on a Sunday, I feel like I've wasted a day because I have so much to catch up on. And I think that's hard for all of us. And that's why for me, it's like I'm never going to say no to an experience for any reason because of OCD. And the nice thing is most of the time it doesn't even come up for that influence. So I just think that reminding yourself, everybody watching this, like you absolutely can get to a point where OCD doesn't influence what you do, and it also doesn't prevent you from having amazing experiences. I think that's so important.
And I now feel offended because I thought I was your best friend, Chris, but you said someone else. So,
I have multiple best friends. You're all invited to my birthday party, and you all can sit at my table, and it's round, so there's nobody sitting at the end. I know, it's so funny. But besides doing OCD treatment, like sometimes, obviously, when clients are getting better, they want to talk. And let me tell you, I have been better, but I did not get prepared to deal with like preteen girl drama. I just, man, it is a beast in its own. Like I didn't get invited, so I'm having a party and she's not getting invited. I have to invite her because my mom's making me, but I'm not going to give her a goodie bag. And I'm like, I'm like, please tell me about how you want to kill 300 people. I know what to do with that, but I don't know what to do that you didn't get invited to Tiffany's party. Like that's too much. I can't do it. Patrick, this one's for you. It says, you mentioned that you wouldn't report someone for those what ifs, but in a case of real event OCD, something really awful took place, maybe inexcusable offenses committed by an OCD sufferer, the guilt and willingness for remorse are tremendous stressors. How to deal with that?
Here's the thing. If something took place, then I have to take a look at what are the report laws for the state that I'm working with somebody in, right? I can't get out of those, but just because something took place doesn't mean that it's a reportable offense, right? So there's that too. Like I would have to report child abuse. I would have to report elder abuse, but as weird as this will sound, someone could tell you, I killed somebody yesterday, but I'm never going to do it again. I have no interest. That's not reportable, right? Because
I know. I remember learning that in grad school. I was like, wait, if somebody says, hey, I killed someone yesterday, I can't report it. They're like, no.
Yeah. It's about if I'm going to do something, right? So there are limits to confidentiality. I have to follow the laws of those things. But when people talk about an inexcusable offense, when I hear that in OCD, sometimes the inexcusable offense was I told somebody to shut up, right? And I don't trust when OCD says to me it was an inexcusable offense. I need to know what it was.
Yeah. And I think that a lot of the times what they're afraid of, is going to happen is OCD in the first place anyways. This got cut off and I don't know how to have a question not be cut off. So I'll have to find that out tomorrow. I have a meeting with Rachel from the IOCDF. But for you, Patrick, it looks like a 17-year-old granddaughter suffering from OCD. She was prescribed Feverin.
I'm giving that to Adam if that's the case.
Yeah. She had, I'm going to say Adam, sorry. She had suicidal thoughts after the trauma. In the description, it says suicidal thoughts are also a side effect of Feverin. They told there's no alternative to Feverin, gave her, I'm guessing that's Risperidone in addition. That makes her very sleepy. Does this sound like anything that somebody with OCD gets prescribed?
So I'll be honest, I had to look that up because sometimes medications in Europe have different names than they do in North America. It seems like Feverin is fluvoxamine or Luvox here in North America. All of the SSRIs have a black box warning for people, for young adults in particular, that they can increase suicidal thoughts. So that is occasionally something that can happen for people, and so we take that seriously. There are other SSRI medications other than Feverin. I don't know particularly in Hungary sort of what is available, but there are other medications and things like, again, I'm assuming, Chris, as you are, that responds is probably risperidone, which is an antipsychotic medication that sometimes is used as an adjunct for treating OCD for people who haven't had an adequate response to an SSRI. But at least in my practice, I usually try to find another SSRI that we can try before we add in an antipsychotic.
Yeah. Well, you guys, we had a lot of questions. So I didn't get to most of them, which I always tell people, if I get a lot of questions, that means that I'm going to have you guys back on because there are so many. I had 4 more that I wanted to get to, but unfortunately, I just didn't get to that. So I am so sorry to all the people that we didn't get to their questions. But thank you so much, everybody, for being invested, for asking questions, for jumping in. I really, really appreciate all of that support. I always want to give you guys the final thoughts. So Adam, any final thoughts for people that are going through OCD treatment or getting on OCD treatment? What are some final thoughts that you have for everyone?
Yeah, again, optimism. There are a lot of good treatments out there. Medications can work for a lot of people. Therapy can work. And for individuals who have tried those things and are still searching for something that might be helpful, we have these, alternative neuromodulation approaches that appear to be helpful as well.
Yeah. Can you speak on that real quick? Because there's questions I didn't get to. When we look at beyond, medication, where are we at with that? Is that something that is experimental still? Or are we seeing really good results and that people should really talk to a provider about TMS, DBS, and other things? Or is it still in that experimental phase?
So TMS for OCD has FDA clearance, and that's been now 5 or 6 years that we've had FDA clearance for that. Insurance coverage often sort of trails a little bit from when the FDA clears a device for treating a condition and when insurance broadly covers it. Studies are still going to try to optimize the improvement that people are getting from things like TMS. DBS also has been around. It does have an FDA clearance. It's sort of through a different pathway called a humanitarian device exemption. So there's kind of parameters around how that is applied, but that is certainly something that some people can benefit from where other things really haven't worked.
Well said. And then Patrick, I want to give you a final word as well. What are just some final words for the community, people with OCD, people struggling, loved ones supporting people with it? What are some final thoughts?
Boy, if you want info on all that, go to this SoCal conference this weekend through the IOCDF, because you will be able to meet people from all over the world who struggle with OCD, who have family members, who are friends, who, if you want to learn about treatments, it's got everything. So that is my advice of the day. Register for the conference this weekend.
Yes, please, please, please. And remember, we have scholarships available. So what Patrick's talking about, if you just joined us, we have a 2-day conference this weekend through OCD Southern California, an official affiliate of the IOCDF. It's a 2-day conference, huge event. Over 1,100 people registered. So we're going to have a lot of people this weekend at the community. Please check out our conference website here, or this takes you directly to the registration for it. And like I said earlier, we have scholarships available. So make sure to take advantage of that. And as always, make sure that you get resources at the IOCDF. There's so much that the International OCD Foundation is doing. So make sure to check that out. I want to thank the community. Thank you, everyone who came out, asked your questions, joined in to the community in the chat. We're here every Wednesday, so at 12 noon Eastern. Next week, I have Kim Quinlan. She's been hosting every third Wednesday with me. So make sure to join Kim Quinlan and myself for more conversations about OCD. So we're here at Ask the Experts every Wednesday at 12 Eastern or 9 a.m. Pacific time, where Adam and I are early in the morning. So make sure you check us out. If you are interested in anything regarding medication or TMS, please contact USC. Look for Dr. Adam Frank, his contact information. And if you are needing OCD treatment and you are unable to find a provider in person in your area, OCD has amazing treatment providers. It's virtual. It can help people from anywhere. They are in so many different countries and states. Patrick, you probably know those stats way better than I do.
Yeah, we work in all over the world. So please check us out. And we take insurance too.
Yes. So make sure to check that out. We will have Dr. Frank and Dr. McGrath back on the live, of course. There was so much interest, so many people chiming in. But until then, I hope everybody has a great rest of the day. Remember that OCD sucks. Stop listening to it. And I'll see these gentlemen back on. So gentlemen, hold on one second for the backstage stuff. But to everybody else, take care and we'll see you next week.